昨天 pace 我都还没看，不过这个是周末的，因为最后一天我们还是对一下片子。这几个还是比较应该是很少见，然后也还蛮重要的。So the first case is a 46. Oh, she's so young. 46-year-old female. This is her pap smear. So she's very young. So for this specimen on low power view, you can appreciate that the background is not very normal. We have a lot of blood. As well as a lot of debris type of material. So not so many cells to see. So that's pretty much what it is. So we can take a higher power over here. So in the background, we can appreciate there are a lot of cellular debris and looks like necrotic debris in the background. So just on the low power, we realize that it is not the normal smear, and the background make you feel like it is more like an invasive tumor, and this is highly likely to be tumor diastasis, tumor necrosis. So then we go to higher power. Most of the cells show remarked degenerative changes that it is not easy to appreciate. For the cells over here, we can appreciate that they are not very polygonal. A lot of them have these like a spindle shape, and most of them are not very cohesive. The nucleus is hyperchromatic. So we have some hyperchromatic nucleus, a lot of like a spindly, dissociative. Most of the cells are degenerated, so it is a little bit difficult for you to tell that if these are viable or not, because they are just dissociative kind of degenerative feature. So for this specimen, we don't have a good population for viable cell that we can make confident diagnosis. However, you notice in the background, it does have a lot of these cells with hyperchromatic nucleus. So in the most common scenario, we will think about that. Could it be a squamous cell carcinoma? So here again, a lot of cellular necrotic debris. And these cells are all so small and degenerative. So when we want to make definite diagnosis, we want to see well-preserved cell. So the cell looks kind of strange, spindle, hyperchromatic, that's it. So for this specimen, we think that it is highly likely that there is an invasive tumor. Because of this hyperchromatic degenerative spindle type of cell, the first guess would be squamous cell carcinoma. However, we do not see keratinized cells, and we do not see good like a cohesive cluster of cells. Most of them were like very dissociated and with a very strange like appearance of the nucleus. And yeah, some hyperchromatic coarse chromatin cells with increased NC ratio, but it's very scant. Most of the cells are degenerated. So difficult to determine what exactly it is. So whenever we see something like this, we need to check if there is any biopsy, subsequent biopsy specimen, because we are not 100% sure what it is. It does not show typical feature of a carcinoma, so we need to pay attention. these might be the rare cases that is not a primary carcinoma. So again, in this specimen, along the smearing direction, you can see these pycnotic, like a degenerative cells, always very different shapes. It is not very big, but you can also identify some bigger cells with a more like a spindle shape, more like spindle morphology. Okay, so this is tumor diastasis. This is necrosis, so this is not good. So the patient do have a biopsy specimen, and then they do have a subsequent hysterectomy specimen. She's very young again, so this is the uterus, so this is the endometrium. The endometrium looks normal. This is the cervix. The cervix looks normal. So likely the tumor is not from the cervix because the cervix is normal. This is the T-zone, transitional zone. And this is the lower uterine segment. And this is the endometrium. So here it all looks normal. So the lesion is not from the cervix. That's why we have very like a degenerative type of cell. So this is actually from above. So what it is? So this is myometrium. This is the uterine myometrium. Here we have a lot of like bizarre spindle cells showing cytoplasmic feature of a smooth muscle tumor. So what it is, this is actually a leiomyosarcoma. So this is a leiomyosarcoma. So we have these invasive nodule inside the myometrium. So this is more toward the surface. So here we start to have the necrosis, some giant cells. So these necrotic debris falling off the uterine cavity, and that's what we see in our pap smear. So we do see a lot of degenerative debris. Some of these like smaller like spindle cells, and these all falling off to the pap smear, and then we have the sample. So this is not a carcinoma, this is actually a sarcoma. Usually when we diagnose primary sarcoma in the cytology specimen, the most striking feature that we will identify is this type of very bizarre, like a very big, highly polymorphic, like a spindle shape of cells. However, in this specimen, this is not what we see because we do not directly sample the tumor area. We sample the necrotic debris area. So all of these cells, shrinkage, have apoptosis, pycnosis, and then fall off to these to the fornix of the vagina. And when we do the smear, we sample these type of debris. So this is the only thing that we see. So what we see on the smear is just like these much smaller pycnotic, highly degenerative cells and mixed with the necrotic debris. Okay, so this is very uncommon in our practice. She is very young. So initially the smear was signed out as carcinoma, NOS. But I would just suggest the next time when we see the specimen like this, when we are not very certain, we just wait until the final result is coming out. We don't need to hurry our diagnosis because we know the patient already had a biopsy. So the smear wasn't add much from the subsequent treatment. So this is a specimen that is actually not a carcinoma but a leiomyosarcoma, and it shows prominent tumor diastasis in the pap smear, but a little bit difficult to appreciate tumor morphology because everything is degenerated. Yeah, so if we see something like this, we might guess that this is a fully differentiated carcinoma. This is reasonable, but it is actually not a carcinoma, it is a sarcoma. So the second specimen, this is coming from an even younger female. So the last female is 46, this is 33. So when we make diagnosis of a positive diagnosis of these very young patients, always very like you need to be very confident for making the diagnosis. So because she is very young, you can appreciate we do have a lot of superficial cells. When you go to the requisition sheets, she actually has repeated HPV infections, including type 16. So she is the had a like HPV infection for a long time. So this is a risk for precursor lesion or even invasive lesion. So for this specimen, the background seems to be relatively clean. We have a lot of superficial cells, so this is compatible with the patient's age. The most striking feature for this smear is that we can find scattered area of these highly atypical spindle cells. So these spindle cells different from what we just see, because the most striking feature is the keratinization. So we realize that these spindle cells are epithelial origin, are squamous origin, and then you can appreciate hyperchromasia, pleomorphism, as well as here we do have a lot of cellular like a choreoresis, which is a process. A process suggests that dysregulation of the cell cycle. So if the cell cycle was dysregulated, the cell with its own like a defense mechanism, it can induce apoptosis of the cells, and you can see the beating of the nucleus. So this is a very classic feature of a neoplastic process. So we realize that there is a typical squamous cell lesions, and it is neoplastic. So what is the appropriate category that we are going to use here? So definitely not low CO, right? So our differential diagnosis is high CO or squamous cell carcinoma, right? So this is not the feature of a high CO. Okay, the high CO wouldn't produce these type of spindle cells maturation as well as individual cell choreoresis. So if you need to choose between the high CO versus squamous cell carcinoma, this is squamous cell carcinoma. So when we want to make diagnosis of squamous cell carcinoma, we just want to check the pattern if the pattern is compatible. So the difference between in situ precursor lesion versus an invasive squamous cell carcinoma is that when you see the smear, for the squamous cell carcinoma, you can actually see the lesional cells throughout the entire smear. So if you go through the entire smear, in the background you can appreciate here we have very atypical looking spindle cells. So they are not along the smearing direction only, they are actually everywhere. So when you go through the entire smear, you can easily find a lot of these unusual spindle cells in the background, like this here. Additionally, we will also see evidence of tumor diastasis, tumor necrosis. So here you do see these are tumor diastasis, necrotic debris. It is actually throughout the entire smear. So the diagnosis here, the most appropriate diagnosis here is squamous cell carcinoma, not high CO. Okay, so you see throughout the entire smear, you have these very bizarre looking spindle cells. and some tumor diastasis. Yeah, here you have more. So these should be called squamous cell carcinoma instead of high CL. So the patient do have a biopsy specimen. So this is her biopsy specimen from the cervix. So this is a very big specimen. In this specimen, we see highly mature papillary fragments of these plastic squamous cells. So apparently, this is an exophytic lesion in the cervix. So here we only have the superficial part. We do have some stroma over here. It's a little bit difficult to appreciate whether this is true invasion or not, but this is still highly likely that it is a squamous cell carcinoma. Just based on this like a histology criteria, this does not qualify yet to be an invasive squamous cell carcinoma, but you can see that it is getting there. So our GIM pathology signed this out as at least high CL, which is totally fine because this is the only evidence that we have on these specimen. These are all high-grade dysplastic squamous cells, but we do not identify invasive lesion. But just by the extent, by the amount of the tumor cells, you know that there must be an invasive foci beneath the biopsy site. So our pap smear is actually more diagnostic of an invasive squamous cell lesion compared to the current biopsy, but you know that there must be an invasive tumor. And because she is very young, she is 33 years old, and she really need to have this information that this is invasive cancer and she can do a proper treatment at her age. Yeah. So I think the subsequent procedure for this case, because in the past smear we signed it out as squamous cell carcinoma, and in the cervical biopsy is at least high CL, so they will go ahead to do a cone to identify the invasive area and to decide and discuss with the patient whether she would like to have a total hysterectomy. And because we know that she's a chronic HPV 16 genotype 16 carrier, and this is likely an invasive more than an in situ carcinoma. So the next specimen is a thyroid fine needle aspiration specimen. This specimen is relatively difficult to interpret. So initially, when we go to like a low power view for this case, it is not very cellular. In the background, we have some cells. It seems to be relatively clean without colloid, some cellular cluster. So the cytotech initially interpret these specimen as oncocytic neoplasm. So what I want to show you here is that the morphology between histiocytes versus oncocyte. So histiocytes is histiocytic origin. It is not epithelial origin. In the liquid-based cytology, sometimes these inflammatory cells can have like a loose aggregation, and it looks a little bit like a cohesive cluster. But if you pay attention to the cytoplasm, the similarity between an oncocyte and a histiocyte is that they all have abundant cytoplasm. But for the oncocyte, the cytoplasm, the texture is usually denser, without vacuole, and it is granular. So here we see most of the cell is very vacuolated. You see these bigger and much smaller, finely like a vacuole in the cytoplasm. Additionally, in these cells, we do see like a centrally located nucleus. A little bit of the cell show a little bit eccentric, but the nucleoli is not very prominent as that we will usually see in a Hürthle cell tumor, Hürthle cells, that the nucleoli is usually more prominent. So this is histiocyte. This is not Hürthle cell. This is not follicular cells with a Hürthle cell change. So what we need to look for is the true epithelial cluster that initially the cytotag didn't highlight the cells. So this is the dot from me. This is again still histiocytes. And here we see a relatively unusual cluster of cells with a very thickened like a cores, but here we do see what it is. This is a psammoma body. Okay, so we have a lot of histiocyte in the background, suggests that this is a cystic lesion. The lesion has a prominent cystic change, cystic degeneration, but we still have these cluster of cells with cells wrapping around this core, and the core do show features of psammoma body. So for a cystic PTC, usually the nuclear changes are very subtle because of the cystic degeneration. You won't see typical feature of a PTC such as elongation, pseudo inclusion. This is like a vague pseudo inclusion over here, grooves, and it is usually not very common that you will see. But this is the cluster that we want to identify, because when we see this, we know there is a very high chance that this is a papillary thyroid carcinoma. So we just need to identify more of these foci. So we have another over here, which is also dotted by me. Again, very similar. We have a secant core in the center, and the core show lamination. The core show lamination and the cracks. So this is a calcified material, and we have some cells around it. And for what is notorious for cystic PTC is this tumor cell gone through cystic degeneration. You can actually see bubble in the cytoplasm, sometimes even hemosiderin. But the whole arrangement, a cohesive arrangement into like a papillary core, these suggest that these are not histiocytes. So somebody would call these a typical histiocytoid cells. So here we start to see irregular nuclear membrane, a vague groove. So this is highly likely to be a papillary thyroid carcinoma. So this is also another cluster suspicious for papillary thyroid carcinoma. So for this case, initial interpretation was TBS4, Hürthle cell tumor, oncocytic tumor, which is not accurate. So this is a PTC. So the problem is how confident that we can call it is a PTC. So this is the direct smear from the same specimen. So this is probably the best cluster that I think is more conventional for PTC. Okay, so this is definitely not oncocytes. So it has a higher NC ratio with these like branching papillary type of growth pattern. Most of the cell have these oval shape. The chromatin is not entirely ground glass, a little bit hyperchromatic, but this is like much suggestive for a papillary thyroid carcinoma instead of an oncocytic tumor. So for this case, we will call it TBS5, suspicious for PTC instead of oncocytic tumor, TBS4. So here again, we have these typical histiocytoid cells. And this is a bigger cluster of cells. It's difficult to see through, but this is more compatible with epithelial cell. So here we have a little bit ground glass of the chromatin, and these are like a what I call decapitated type of arrangement for papilla. And the screener, the dot by the screener, let's take a look. So this is cohesive cluster. So it was thought that it is oncocyte cluster, but this is actually a cluster of histiocyte. You can appreciate these highly bubbly cytoplasm. So this is actually histiocyte, not oncocyte. You can take a look of a little bit more over here as well. So again, this is more likely to be histiocyte. So we can appreciate the bubble cytoplasm. And I have to admit that indeed, some of these cells do show more like a dense granular cytoplasm, but because we do see these bubbles in the cytoplasm, this is likely not an oncocyte. This is more likely to be histiocyte. In addition, we do see fluid background in the conventional smear. So this is a histiocyte, and the final diagnosis is suspicious for PTC. So this is the direct smear from our endocrine department. So this is from the thyroid again. So we don't have liquid base for these specimen. So the patient, the history is kind of unusual. The patient, I think he or she had maybe schizophrenia, so admitted to our psychiatry ward like frequently, and because of the medication that he used, he got the frequent aspiration pneumonia. So he admitted in our infectious ward for control the aspiration pneumonia. But during the admission, they find out that there is an unusual marker keep on a very high level, which is procalcitonin. When I was the medical student, we don't have these serum marker, but apparently it is a marker to indicate that if the patient is in acute inflammation. So the procalcitonin will be elevated if the patient had an acute inflammation. But after the inflammation control, he still had a very high procalcitonin. So that is kind of unusual. So they start to think about, could the patient had medullary carcinoma? So like what I say, medullary carcinoma is unusual in our hospital. Usually we will see one every 1 or 2 years, but this year we have many cases already. And so this is the aspiration from a big thyroid nodule. Is almost 4 centimeters, 3.5 centimeters. So it has been with the patient for a long time. So when you take a look of the specimen, on low power, there is no colloid in the background, only the blood. On high power, you can appreciate that we have a lot of individual cells. So the cell doesn't cohere like what we see, like a honeycombing or like a three-dimensional cluster that we will see in other thyroid tumor. Maybe there is a vague microfollicular pattern, but these can also be the rosette pattern. So if you think that if we are in the pancreas, when you see the specimen like these, so the first guess would be neuroendocrine tumor. So basically, medullary carcinoma in the thyroid is the thyroid version of neuroendocrine tumor. It is a neuroendocrine tumor from the thyroid. So it will have a very similar appearance of the pancreas neuroendocrine tumor. So we've seen some different cases these years, including a more pleomorphic version, included a more spindle cell version, and this is the more classic version that we see, which is showing uniform rounded cells, mostly discohesive. A lot of them show plasmacytoid feature, and the nuclear chromatin pattern is classic neuroendocrine chromatin pattern, which is salt and pepper. So this is the classic feature of a neuroendocrine tumor, and if we are in the thyroid, it is likely to be the thyroid medullary thyroid carcinoma. So the clinician already do the serum calcitonin level, which is very high, 5,000. I never seen this level. And according to the textbook, if the initial calcitonin level is really high, such as like about 1,000, and the prognosis is worse than the initial calcitonin level is just a few hundred. Additionally, the patient also has elevated CEA level. So this is a classic serum finding that we will see in patient with medullary thyroid carcinoma. So when we think about medullary thyroid carcinoma, about 2/3 of the cases in the aspiration, you expect it that you will find amyloid. So this looks indeed like amyloid fragments. It is very different from colloid because of the border is very sharp. And you can see some like irregular thickening in the material. And usually the amyloid material will push the cell to the edges of these material. So this looks like an amyloid. So because clinically we already know it is highly likely to be medullary and the cytology is compatible. So this is a medullary thyroid carcinoma. So we can call this TBS6 malignant, and we will make a specific diagnosis of medullary thyroid carcinoma. So that's for all the case today. Okay, so we can, yeah, sure. So we can start